Good morning, everyone. It is Friday, January 21st. Welcome to the Morning Medical Update. Thank you so much for joining us here on Facebook and on YouTube. Coming up today, we are taking you inside the Decedent Affairs Department, otherwise known as the Morgue, how the Omicron surge is impacting the work they do there, caring for our deceased patients. Also, changes to the CDC's masking guidelines can be confusing. So Amanda Cackler, Director of Infection Prevention and Control, she is back with what you need to know to make sure you are best protected. Plus, also back, Dr. Tim Williamson, Vice President of Quality and Safety. We're just going to get an update about hospitals, from the ER to the ICUs, how the surge is impacting staff and what they are doing. We're also going to talk about the change to what fully vaccinated really means. So make sure you get your questions sent into us on YouTube, Facebook, and email us at the Medical News Network. You can find links right there on your screen. But first, let's get to our COVID count this morning with Medical Director of Infection Prevention and Control, Dr. Dana Hawkinson. Good morning.
Hi. Yeah, I would bet that it's not just about masks that a lot of people would find confusing about the CDC messaging, but it's probably about all of those topics and everything we probably haven't even talked about yet. So, but anyways, for cases, we do have 124 active infections, 23 in the ICU, 28 in the ICU and 14 on the ventilator. Still 79 in that recovery period, so a total of 203 infections, again with 124 being active. Still, our last inpatient death was over the 19th, so we've had a little bit of reprieve from that.
All right, thanks for that update. All right, we've got a couple of reporters on the line, so let's get to those questions real quick. What you got? No questions. All right, we'll check back with you in just a little bit. Let's get to Amanda Cackler and Dr. Tim Williamson. Thank you both so much for joining us. 2 Fridays in a row. It's a great way to end the week. I love it when you're here. Lots to talk about. Okay, Amanda, I'm going to start with you. People think that the CDC says that cloth masks are not effective against Omicron and are suggesting that we only use N95 or KN95 masks. Is this true?
Yeah, you've changed the way you're going to ask that question.
Well, you wanted me to ask it wrong, so you could say, no, Jessica, you are wrong.
No, I wasn't going to say that. I think, though, there are a lot of headlines out there that suggest that the cloth mask or even an ear loop mask, a surgical mask, aren't effective against Omicron. And on Friday, January 14th, the CDC came out with, it wasn't really new guidance. It was really more what masks exist and how do you pick the right one for you in the setting that you're in. Mm-hmm. So they did provide some guidance in regards to which masks offer the best protection against any variant of SARS-CoV. And we know that masks continue to be one of the best tools for the prevention of transmitting the virus from one person to another, with cloth masks being the probably least effective, surgical masks, and then respirators. However, the key element here is any mask is better than no mask, which we've been saying for probably months now. And then the other really important piece of this is the way that those masks are fitted. So you might have a double layer cloth mask that's very tightly woven, and it fits your face very well. It covers your nose, it covers your mouth, it covers your chin. There's no gaps, and that's providing some pretty good protection for you in a public setting. Then there's that ear loop mask, which is going to provide a little bit better protection, provided it fits well.
A surgical mask.
A surgical mask.
Okay, so
yeah, sorry.
you have one.
Well, I do. I do
Yeah.
have an example. It's not what you probably traditionally see because it's black in color, but it is a surgical mask. We call these ear loop masks. We call them surgical masks. We might call them procedural masks. They're typically a disposable mask. You wear it once and then you throw it away. Because they can get wet whenever you're speaking into them. So this is one that I just purchased, and you can get them online. These are really readily available in grocery stores.
I was going to say.
You can find them anywhere right now.
Yeah.
But it is also important to acknowledge that not all masks are created equal, and that comes from cloth masks, that goes for surgical masks, that goes for respirators. We know that especially at the beginning of the pandemic, I think there was even a study that suggested 60% of respirators that were available weren't actually meeting the need of protection. So you have to be really careful, and there's markings on the inside of respirators that denote they're an approved vendor and that they do meet the criteria.
So does the kind of mask you wear depend on what you're doing?
Absolutely.
And where you're going?
Yeah. So like my favorite mask is a cloth mask. It's one that is multiple layers, which is key. So it's got various layers of fabric in here, and when I put it on, it's not going to fit well because I've got this earpiece in. But when I put it on, there are no gaps. It covers everything. When I breathe in and out, I can feel the fabric coming close to my mouth and in and out. When I put this one on, it actually gaps quite a bit on the sides and on the top of my nose, and it tends to fall down. So even when I put the fix in place to make it tighter and do that little extra loop around my ear, then it creates a gap on the side. So a way to actually kind of combat that is you could double mask it, and whichever one fits the best you can put closer to your mouth, and you can put the other one over it. That also offers another layer of protection. And then we have the respirators, which is what absolutely the CDC has said provides the best level of protection. However, not everyone can tolerate wearing a respirator. They're a little bit thicker. They do tend to fit a little bit tighter. And depending on the activity you're doing, you may not be able to breathe with it. And if you're taking it on and off, that's not providing you protection.
And are those the KN95s?
It could be an N95 or a KN95.
And I wore one of those for a story that I did a couple days ago, and it definitely takes some getting used to. But you feel better protected.
Sure. But that again is if you're not constantly manipulating it so that you can take a breath and breathe in whatever's around you. In the healthcare setting, we expect everyone, especially in our patient care settings, to have at least a surgical mask on. And then if you're taking care of a COVID-19 patient, you have the option to wear an N95 or a different type of respirator. In the general public, depending on where you're going and what the masking practices are of the environment that you're in, a cloth mask may be just fine, or you may feel better protected with that surgical mask or double masking, or you may decide that a respirator is what you choose to wear based off of your medical condition or your vaccine status. So what it's giving you isn't you must wear this one. It's telling you why you might pick one mask versus another.
Sure. And when you say double masking, any type of double masking, or a lot of people ask, can they put a surgical mask over a surgical mask like your black one over a cloth mask? Is that effective?
So I believe the one recommendation for double masking, like you certainly shouldn't put 2 respirators on. That will probably prohibit your ability to breathe very well at all. And the way that the CDC has marked it, I believe, is that they actually recommend the surgical mask on the bottom and the cloth mask on the top, which is a little bit counterintuitive. And really my interpretation would be that you put it on the way that is going to, whichever one fits the best, closest to your face, and then put the other mask over the top. And again, provided you can still breathe comfortably.
Okay, my head is spinning because here we are 2 years into it. And Dr. Hawkins, I'll let you jump into it because who knew that we'd have so many questions about masking? We get so many every day, but I'm kind of glad because that means people want to know how to do it right. You know, what advice do you have? What are your thoughts?
Yeah, absolutely. I think Amanda explained it very well. You know, we know that data is there. We know early on in the pandemic there were basic laboratory studies looking at mask filtration rates, and we knew that they had said that the N95 or KN95 filtrated the best, or was a barrier the best compared to surgical masks and compared to cloth masks. We know that in the real world, in a good randomized control trial, the big study from Bangladesh that actually proved that masking in communities does work to reduce the spread of disease. We know that they had said that the surgical mask did work the best as compared to other cloth masks. But to the point that Amanda did make, you know, it has to be a 2 or 3 layer, tightly woven cloth mask. And again, the main messaging is any mask is better than none. And if you can have a better fit around the sides and top of the mask, that is really what is important and what you should be going for.
Okay, 400 million N95 masks are going to be distributed nationally for the public's use. That's going to happen next week. What effect do we think that might have?
I think it's great that the availability is going to be there for the general public. I think, again, it's going to be, you have to pick a mask that you are going to commit to wear. And in some situations, an N95 or a KN95 just may not be comfortable. But if you can tolerate it and you're going to wear it the right way, that's wonderful. because we do know it provides such a good level of protection.
And I think that instead of surgical masks and gaiters found on the sidewalk and in the gutters, there'll probably be a lot of N95s now found in the gutters.
Yeah,
okay, good.
Very unfortunate.
Right, and then, so Dr. Williamson, I'm not letting you get out of this conversation. So when we talk about these type of measures taken to try to make it as widely available to everyone, does it give you hope that we'll see any sort of change in numbers?
It gives me hope, but at the same time, I think both Dana and Amanda were getting at this. They have to be on faces. So masks in pharmacies don't necessarily help. Getting them to people who will wear them will make the difference. So if I don't know that lack of availability has been driving the masking practices in the community, but for anyone that maybe it did, awesome. If there's more availability, that's great. But at the end of the day, it's really got to be about wearing the mask, wearing the one that's the best fit. And Amanda did a fabulous job of walking through that. So.
And two other components, because I think it's important that you just said that. Just having it available in the pharmacy doesn't mean it's going to put it on faces. And we've seen that with vaccines.
I was going to say, we were going to say the same thing exactly with vaccines.
Unfortunately, we've seen that with vaccines. And then the other thing that I think we still have to learn about is that we had Omicron in a setting where we weren't also having masking mandates.
Yep.
And so what does that effect have, period, of if masking dates do come back, or if the community just decides that they're going to start wearing masks more than they were, will that just have a really good impact on our reduction in cases as well?
All right, let's keep going. Let's talk about the vaccine. Explain what fully vaccinated officially means.
Yeah, so the CDC's been busy putting new information out on their website, which is fantastic. They did come out with, there's a lot of semantics when it comes to vaccination. Are you fully vaccinated? What does that mean? And fully vaccinated for one manufacturer and one age group may look a little bit different based off of medical conditions and that sort of thing. So when we talk about primary series, that could mean one dose of the J&J vaccine. If you're 18 and older, it could mean that you received 2 doses of mRNA vaccine if you're in that age range, and you also don't have medical conditions that put you into actually what a primary series would require you to have 3 doses. Any one of those would be fully vaccinated, and then this concept of up to date means you've also received the booster dose based off of you waited the 6 months in between your last or completion of your primary series. So that change where they've come out and been cleared up or attempted to clear up what does fully vaccinated mean also makes it a little bit of a challenge. And I know you're going to ask some questions about what is our vaccination rate here in the hospital. And so when the CDC makes changes and ACIP makes changes, then our medical record vendor has to make technical specifications to make sure that when we're documenting information, it matches up to the most current guidance. And sometimes we have a delay because the CDC publishes, ACIP or vice versa, they have to have their regulations published. They can't start working on those technical specifications until that time, and then we can see it go live. So there's been a little bit of a delay to make sure that the information that we have is accurate and up to date. So we're working through that right now, and we'll hopefully have that information available very, very soon.
All right, let's talk about at-home testing for COVID. Is there concern that there could be more spread because people aren't reporting it? How does that affect numbers?
I think that probably is something that we're constantly dealing with because there isn't any mandate that says if you're positive you need to report it anywhere. So there could be additional spread that we're just unaware of. And there's plenty of people who aren't testing that we just are unaware of as well.
Yeah, and I'm glad people are taking advantage of the home test and so that they're knowing if they're positive or not. I think the important thing is they take the appropriate precautions if they are positive and they're isolating and they're staying away from other folks. But to that point, we know that the case numbers are probably grossly under capture the number of true positives in the community because there is so much home testing and those don't go anywhere. Those aren't reported anywhere. So the case numbers are much higher than whatever's reported in the media or on the dashboards because of that home testing. But I'm glad it's available because some of the PCR testing is harder to access, just because of the demand right now. So if folks are doing that at home and using that information wisely, that's great.
So is the home test like a game changer? As far as for people who just say, I'm going to wait it out, I'm not going to go get the PCR test. I mean, does this help? Do we start to see any effect?
I don't know if it's...
As far as knowing and people actually then doing what they need to do to stay safe from everyone else?
I think it's helpful. Maybe it makes it accessible for folks who otherwise wouldn't have it. But if you're symptomatic and it's negative, that doesn't mean that you don't have COVID necessarily, because those home tests can, particularly with Omicron, they're not as sensitive. So a positive test, we take it at its face value. That means you have COVID, and particularly in the setting of symptoms. But if you have symptoms and that test is negative, then you probably need to test again in a couple of days or get a PCR test, or at minimum just isolate and treat yourself as if you have it.
Okay, we all need to be taking notes on this. It just seems like there's so much to know and remember, and
it's not easy. Like, it seems very, if you have a negative test and you're telling me that means nothing, then why did I just take the test? And it's like, well, you're really looking for that positive to confirm your diagnosis versus the negative, which unfortunately doesn't mean a whole lot.
And in fairness, Jess, we live this every day. I mean, we're like neck deep in this, and we have to go to the websites multiple times a day to make sure that we're doing and saying the right thing. So it is not easy.
Okay, so I'm not the only one sitting here. A lot easier for you than me, but that's why we bring you on.
All three of us.
So as much as the disease is causing weariness, the keeping up with the actual terms and guidance and just trying to understand that can also cause weariness.
Yes, this is what we rely on you for, to help us keep up to date on this. Okay, so Dr. Williamson, we have heard you say that right now we are in a canoe, in a river, and there is a fork ahead. What do you mean by that?
Yeah, so this whole COVID experience has been much like a river, and it's carrying us down. We find ourselves kind of, though, in an unusual position in that we don't know which fork we're going to take. And so on one hand, we see that that cases maybe are peaking in the U.S. with Omicron just now, starting to peak. They're peaking on the East Coast. We not necessarily have seen that locally or in the region. And then hospitalizations will follow that. So hopefully we're, within a few weeks of seeing the cases come down, the hospitalizations come down. We're in a position, more of our staff are back and not out sick. We're in a position that we're maybe not going to have to reduce as many surgeries. So one of those forks is kind of calm waters, where we're making headway and getting back to where we were before this surge. On the other hand, we know that those hospitalization curves, nationally, locally, regionally, and you saw the numbers today, our numbers are really not going down. Those curves have not appeared to peak or even started to plateau. They're going straight up. So as those numbers continue to go up with hospitalizations, it could be a rough couple of weeks. So we are also trying to prepare, what does that look like if we continue to get a large number of COVID patients on top of already the number of other patients we have? What does that look like? So we it's hard to know right now. Do we have calm waters ahead? Do we have rough waters ahead? And we're really trying to prepare for both of those scenarios.
So is it like the difference between standard care and crisis standard of care?
Yeah, and if we can talk just a moment about crisis standards of care, because those words get used a lot. I know a lot of hospitals in the community around the country are talking about that. And it's really a spectrum, and there's no defined definition of what crisis standards of care means. It's really a spectrum. And so we, I think there's kind of standard operations. And then once you're not doing your standard operations, there's probably 3 levels. There's kind of the first modifications to your operations, where you're reducing surgeries, you're reassigning staff from non-clinical positions to the bedside, which Amanda's team has done and other teams have done. You're making reductions in your ambulatory visits. And we've done a lot of that, those kind of first adjustments. I think the next level, which we're not at, and we hope we don't get to, is a bit more impactful, but it's stopping all surgeries that are not emergent, and really using different sorts of staffing models, et cetera. And then the point that I don't think we'll get to, and that we hope we never get to, is that true crisis alternate standards of care requires an emergency order, requires legal declaration, and that's where really a triage plan is in place, and we work on that. We have those plans in place, but hope, again, and don't expect we'll ever have to use those. So there's no doubt that for any hospital in the region, it's not business as usual as we adapt to the surge and the things that are coming. We're all in some sort of adaptation where we've reduced surgeries or we've made other changes with our with who we bring to help staff. But but we're all watching this very carefully, and we'll adapt as we need to in the moment.
Thanks for bringing that up and kind of breaking down exactly what that means, because we do hear crisis standard of care a lot. Okay, so I want to ask you about a couple of specific areas in the hospital system. Yesterday we took a look inside the ER. I want to start with that. Are things easing at all there, or steady, kind of?
I think steady high. And I just want to say, for those of you, you guys don't see me every day, I had a viral thing about 6 weeks ago, non-COVID crud, I call it, and that cough has hung on for like 6. So if I cough, that's hung on for like 6 weeks now. So okay. I don't want people thinking, what's he doing up there?
Yeah, we do give people weird looks when they cough.
I know.
But I think that's a good example of even other non-COVID or non-influenza respiratory viral illnesses. You can have a lingering cough for several weeks after that acute phase.
It can be other things. Okay,
but back to your question. The ER, the ER is busy. It's up over 200, averaging over 200 visits a day for our ER. I think all the ERs around town, again, remain very busy. Lots of ERs around town continue to have folks who have to remain waiting for beds in the ER. So that really has not slowed down any, and probably won't for the near future.
All right, I want to talk about the ICU. Mm-hmm. I know we have some video that we have recently shown, and we have seen these images throughout this entire pandemic. But what can you tell us about what's going up on those units?
They're busy, and so in general, maybe in this current surge, we haven't seen the same level of ICU involvement and ventilators that we did with earlier surges, but they're really busy. And you heard, I think Dana said we have 28 COVID patients in the ICU, but that's just COVID. We've got all the other things that typically need ICU care in our hospital. When you think, I off the top of my head, I want to say we have around 115 ICU beds. So we've got just under a third of our ICU beds are dedicated to COVID right now. So, and those patients require a lot of care. They often require proning, which is turning someone onto their stomach for long periods of time. And when you have all that life support, that is incredibly difficult to do, and particularly when you're wearing all the protective equipment that you see there. So this is it's emotionally draining, it's physically draining, and those teams have been doing this now for almost 2 years coming up. So it's hard.
And you're watching proning right here, and the amount of staff that it takes to do that, right, Amanda?
Yeah, and you made a comment about staffing, and we've talked about this before. The shift that we've had, I'm in scrubs, which I'm not normally in scrubs, but I'm helping out in a clinical setting later today. Most of my team, if not all my team, is helping in some fashion, either helping out the vaccine clinic, the swab clinic. I've got a physical therapist who's actually been trained to do nasopharyngeal swabs because we have that great need right now. Throughout the organization, teams are chipping in. We've got statisticians helping with our environmental services. We've got vice presidents transporting patients. We have just had, both in the clinical and non-clinical setting, everyone chipping in to support our normal operating function.
And I would just say about that video that we saw in terms of the ICU, that patient had a lot of equipment around them. That, I would say, is on the low end for someone really sick with COVID, and or you didn't even get to see all the equipment in the room. When you see some of these patients who are on either life support or the heart-lung bypass machine and dialysis and all of the different drips, believe it or not, the amount of equipment and the amount of people there is on the low end of what some patients require in terms of their care.
All right, I want to talk with you too about a story that I had a chance to do a couple days ago, and I'm going to give my perspective, and then I want to hear your perspective as well. But we had a chance to visit Decedent Affairs this week, otherwise known to people as the Morgue. I do want to mention that the following video does show deceased patients in bags in our refrigeration rooms. So I just wanted to make folks aware of what they are about to see. We could go ahead and roll the video, but we felt it was just important, not that just showing this image of full rooms, but just to let folks know that the teams down there are tired, just like what we see up on the ICU floors. They are saddened to see the word COVID written on body bags, but by taking you all inside this area, it continues to be that constant reminder that these these are people. These are people's loved ones. Dr. Sierra Wright showed me around, and what really actually surprised me most was a place that I imagined in my head to be cold and dark, was actually quite peaceful. And I came to realize that these patients are still patients even in death. They have dignity, they're well taken care of until further arrangements can be made with the hospital and the families. But simply capacity is the issue. Staff work hour to hour, just like other busy areas of the hospital. And I just kept thinking to myself, no one wants to think of themselves here, lying here, or a loved one lying here, especially with the word COVID written on a bag. But Dr. Williamson, you know, it also had us thinking that, you know, people come to a hospital to get better. They don't come to end up here in the morgue. So these areas just simply are not built and equipped for that kind of a capacity.
Yeah, so we have throughout this seen some of the highest numbers of deaths globally that we've seen throughout the pandemic. I think right now we're about 29 deaths or so for the month of January so far from COVID specifically, which is more than we saw in the entire month of December. And there are so many unsung heroes of COVID, and one of them, we haven't shown this before, I don't think, and some of those unsung heroes are the folks who work tirelessly down there, and it's hard work, and they're making sure that those patients get to the appropriate funeral homes. And we are right at the edge of our capacity any given day about being able to manage the number of deceased patients down there. And when we exceed that capacity, and we hope we don't, but then we would need to bring in additional refrigerator trucks. Other places have had to do that. But I just can't say enough about the people down there who are, as you say, continue to take care of these patients with utmost respect and help their families. But it's hard, you know, but it's very real. That people, you know, I think all of us really hesitate when people call Omicron mild. And there are people that still die of this disease. Not to mention we still probably have a fair amount of Delta in Kansas, but it doesn't really matter. People are still dying of this disease. And they don't think that when they come in the doors necessarily, but that's still a very real outcome.
And similar to what we would talk about when patients would come to our hospital, and we'd have to say, you know, you don't want to get COVID because you won't be able to come in and be with your family. And those, you'll be Zooming, you'll be communicating through nursing staff. What I learned was down there, something I did not know, that there's a room very similar to like a viewing room at a funeral home. They're handling families like what you would think would be the interaction of a funeral home, and mourning families, very sad and devastated. But due to COVID, those viewing rooms are not able to be open. So, you know, Dr. Wright was saying people will call down there and, you know, want to find out, or when they'll be on their way to come see them, and they have to turn them away. But
yeah, and that's something, again, due to our capacity, that's something that we used to be able to do on the unit. And now, once that patient passes away, we need to get that another patient in that bed, so we move them down to the morgue, and the viewing room is there for that reason. But it is definitely a struggle that we've had to be prepared for this entire time.
It was a big learning moment, and that's what, again, we wanted to share with folks to, again, kind of bring it home, not to be cliche, but to show all areas of everyone working together to make sure all patients are taken care of. So Dr. Williamson and Amanda, what kind of planning, though, goes in if we talk about getting through this Omicron surge and then we think of maybe possibly another one? What kind of planning goes into it if we were to be at capacity in a place like the morgue? You mentioned the trucks being brought in, but is that a real concern?
I think it is, and I can't, off the top of my head, I want to say that our capacity is less than 10 down there. I can't exactly remember the number.
9 patients can be kept inside the refrigeration rooms, and sometimes they have to bring people out while they're waiting for a funeral a funeral home to arrive. But it's a small area. I thought
really
it was a much bigger area, and I don't know why I thought that. I think it's probably because that's what I had in my head from a movie or a show I saw. And I went down there and I said, oh, this is it. There's not a lot of space for people. And sometimes Dr. Wright will walk in the morning and there's several beds, transporter beds full outside of the refrigeration rooms, waiting for her to come in and make contact with the families in the funeral homes.
Yeah, so I think it's just constant communication with them. What level are we at? What do we really need to be preparing for? And I know we've started having those conversations about what's our what's our next step for capacity for the morgue, we were having those conversations back in April of 2020.
Well, that's what I was going to say, because we would see those images out of New York where we
Yeah.
would see them taking bodies outside to trucks waiting out on the curb. It was quite shocking.
I remember that first conversation, and it really sort of set a silence to the room that, I don't know that we've ever had that conversation before. At least I've not been a part of that conversation before.
Oh, when you think of baseline, this hospital's grown by leaps and bounds. You know, I have been here since the mid-'90s in one way or the other. And you look at how big the hospital's grown, but our morgue capacity really hasn't. So just at baseline, and then you add COVID on top of that. But so, like I said before, we're right on the cusp of needing more capacity. And the only reason that we're able to get by without additional, for example, freezer trucks, and which we really don't want to do because that seems, I mean, that's very impersonal, is because they do such a great job down there of getting folks to funeral homes and getting them to the next step in the process. And the funeral homes have done a good job of helping with that process as well. So that would be the next step, would be, and we kind of constantly ask, when is that time? And we actually did bring in freezer trucks at the beginning of the pandemic. We never had to use them. They were on standby, and so we know that process. And like you said, others have done that as well. But
it's always the hope we're not going to get there.
Right.
But being prepared. A couple more questions before we get to our community. Just Dr. Williamson, let's talk about transfers. Any updates there?
It's still really, really tough. And one of the folks who helps take some of the transfer center call in terms of helping look at our capacity and stuff. And so we're still on track for about 2,000 transfers in the month of January, which is about what we had in December, knowing that our baseline pre-apocalypse was 800 or 900 transfer requests. Those are requests. And we're only able to take somewhere around 15 to 20% of those just because of our capacity. And it's the same all over. And we hear the stories of folks not being able to get COVID or not, heart attacks, trauma, other stuff. In other smaller hospitals, they still have a very hard time getting into larger hospitals around the metro, around the state, Wichita, Topeka. So transfers are still incredibly challenging to get sick patients where they need to be.
All right, thank you for that update. Dr. Hawkinson, I'm going to end on you. So we're out with Steelers fans, we're in with Bills fans this weekend. Just any advice for people to stay safe as we go for another win, but we don't want to go for any COVID. So
yeah, I mean, it's the simple advice, because we are following the Chiefs to the Super Bowl, and we would like everybody to be well and healthy and be able to watch that Super Bowl in their house. So I think it just goes back to those basics again. Masking is extremely important. Understanding those situations that you're in. If you do have to meet and gather with people, please do it outside or in a large and well-ventilated area. Hand hygiene is important, and really also vaccine continues to be important. This is a perfect time to go get vaccinated. We are still in the cold winter months. We know the cases are still high. If you haven't been vaccinated or you are due for a booster, please go get those shots into your arms. And I think that is the best advice that we can give to try and keep everybody safe as we continue to move through this current surge, and hopefully keep everybody well and safe to move forward. Watch the Chiefs win the Super Bowl, watch KU win the national championship in basketball, but I think that's important.
That all sounds like a bright spot. All right, thank you for that advice and words of wisdom. All right, let's get to some community questions today. We've got some good ones. Christine wants to know, what is an average number of deaths in January in a non-COVID year? Can you help put that into perspective, Amanda?
I don't know I wasn't ever tracking deaths like I have been since 2020, so I don't actually know. I know you might have had a better sense of that.
Yeah, I don't know off the top of my head. I think that's a great question. We look at the overall raw mortality, so just the percent of patients that come here who pass away. That number is a little closer to my mind. So typically before COVID, we would have an average monthly mortality of around 1.5, 1.6% of the patients. And I think last month we were around 2.5, 2.7. We've gotten up in December of 20, we were up around 3.5%. And that's driven by not only COVID, but because it's so hard, people here are sick. You have to be really sick to be in a hospital. And so the acuity is so much higher as well. So we see more deaths.
Yeah, that makes sense. Shirley wants to know, do the bodies of COVID patients need to be handled differently because of the infection?
So I think the answer to that is yes, but we also have other diseases that patients die of. So it's basically our standard and transmission-based isolation practices that we handle any patient who dies and we have a known infection associated with them.
And when I was speaking with Dr. Wright, she had mentioned that that when a COVID patient dies, they are double bagged up on the unit, and then they're brought down just like any patient would, and that the reason they write COVID on the bag is just as an extra layer of precaution. She said that we don't normally need it, but just in an abundance of caution, we do that so that anybody else handling the patient thereafter is
aware.
It's just aware.
Yep.
And the other difference is we're not equipped to do autopsies on COVID patients, and so patients who die of COVID, we're not able to do autopsies on them because we don't have the ventilation set up to do that.
So they would be sent somewhere else for an autopsy if they needed
well,
it?
the more likely fact is that they just would not have an autopsy, which is usually not a question of why they died. So it's not necessarily a big difference, but it is a difference.
And Emily, I hope that answers your question. She was asking what the purpose of writing COVID-19. Is it a hospital policy to write the cause of death on a deceased body? That is not normal.
No, just
No.
because special precautions are needed.
Okay, another question. When we talk about current numbers, Emily, another Emily has a question. When we talk about current numbers in ER and ICU, what are normal numbers in those places? You know, even if you're not super specific, I mean, heightened, I mean, what would be normal feeling to compare?
You know, normally in the ER, I mean, this is certainly high, some of the highest numbers that we've seen, and across the metro region. And I can't give you the exact numbers off the top. I think it's a great question, and I think we probably need to be better about putting that into context of, okay, we have 200 patients a day. What's normal?
Right.
But that's a substantial increase, and those patients again are sicker, and they have to wait longer again around the community because those ERs are so full. You know, the ICU beds are a little different because they're limited. There's only so many of them, so you can't kind of exceed that capacity, so to speak, like you can in the ER, where people can keep coming even if there aren't necessarily available spots, so to speak.
I said maybe we turn to an easier topic, masking, but doesn't seem so easy
and
today.
Before we jump into that, I know that as you mentioned, the morgue really hasn't, you know, it's been the same size since the beginning. We have continued to expand the size of our emergency department, but I don't know that we've ever been in a situation where our emergency department isn't just crazy busy all of the time. Even as we expand beds, patients come into those beds. So I think COVID has just kind of made that a little bit more difficult to manage. And just from my experience with being the nursing director on call sometimes, ICU capacity is something that we used to have. We used to have several beds that we could sort of flex if we needed to. And with COVID, we've really kind of lost that ability to.
And I think along those lines, you think about it, you know, we have roughly 200 patients with COVID right now. That's 200 patients that we wouldn't have had 2 years ago. And so when you look at our overall capacity, those 200 patients with COVID, that's a big chunk of,
I think that right there just put it into perspective.
You know,
just thinking of it in that term.
That's, you know, if we have roughly 800 patients, you know, that's a quarter of our patients on any given day might have COVID.
So Kim wants to know a couple things about masks, and Dr. Hawkinson, jump in with what you have to add as well. But what about going back to washing masks? I mean, that was a thing when we, I think people have gotten away from that, let's be honest.
I hope not.
I know that's not news you want to hear. But people fling in their mask and throw it in their car seat and in the bottom of their purse, or, you know, not bagged, not clean, not washed every night. Thoughts?
I think
I
a
think you
clean
should.
mask is still an important thing. I mean, you're still putting it very close to your face. As you're breathing, there is some bacteria that might be on there, so you might notice skin breaking out because of that. Still, the guidance is that you wear a clean mask. If it's soiled or if it gets damp, you should dispose of it, especially if it's a disposable one, or wash it, just like you would any other laundry. But I think a clean mask, trying to build that habit of cleaning them, after, it again depends on if you wear it for 1 hour, you probably don't need to go and launder it. But if you've worn it all day for 6 days, you probably need to wash it. Yeah.
Wash it, right? I don't think you could disagree with
Think
that.
of them as socks.
Okay, so what about, you were talking about the disposable ones, wear it, throw it out. So then the question came up, are they recyclable? Can you put those people who want to be environmentally friendly?
What?
I get that.
It's a great question, and I honestly don't know. I'd probably have to look at the back of the bag or the box.
Okay,
to
we
see
can
if
find
they're-
that. We can find that out
And I
for
don't know
sure.
if all of them have the same recyclability.
Okay, you gotta get up. We have to get up on our recycling.
Yeah, but I do
standards.
know that there has been some pretty strong studies, not studies, but looking at what have surgical masks contributed to in regards to pollution and in the ocean, and that's just a side effect of all of this.
Yeah, that makes sense.
Don't leave them in the parking lot. Don't leave them on the
That
gutters.
must drive you crazy.
It does.
It does. Okay, we don't want to do that. Okay, so Catherine wants to know, Amanda, can you also address CDC isolation guidelines?
My favorite topic. Okay, so these have changed a little bit, and it's right now I've got 3 different guidelines in mind, because we've got what the general population has been when they changed the guidance for isolation. So isolation being that you have a confirmed positive test of any kind. So you still should be in isolation for that 5 days at a minimum, and then they have said you can kind of go back out into public, or as long as you're wearing a mask for that additional 5 days. As it relates to the healthcare workers, which is kind of the setting that we're used to, you maintain that isolation for 5 days. At day 7, we are actually bringing you back to work because of our staffing shortage, but you have to be without a fever, your symptoms have to be resolving, and we still expect that you're wearing a mask. Obviously, in the healthcare setting, you're always wearing a mask. Right now. And then we have inpatients who have a whole different set of isolation guidelines, and they're, depending on why they're here, could be 10 days or even extend beyond 20, 28 days, again, depending on their symptoms and their underlying medical conditions. So again, another changing or evolving situation with COVID that does make it a little confusing.
This is why we keep having you back on.
And I would say, too, that is the CDC recommendation and guidance. Again, it's not just for necessarily medical purposes. It is for probably economic and getting people back to work. We do have pretty good science and data, though, to suggest that you still have a good amount of infectious virus at that 5 days. So if at all you can stay isolated for a few days longer, say 6, 7, 8 days, that will decrease your risk of being able to spread it to other people as well. So I think that's important to note. If you at all can stay isolated for more than 5 days, it'd be a good idea to do that.
Doc Hawk, Larry wants to know, when is Omicron most contagious?
I think that's a great question. Again, just like the other variants we know, it's probably 1 to 2 days prior to any symptoms. And that's the big thing with this disease, unlike the first SARS epidemic, where you really weren't contagious until several days after symptoms started. With SARS-CoV-2, you continue to be contagious now 1 to 2 days, sometimes 3 days prior to you even knowing that you have symptoms. And then most contagious 2 to 3 days after that, with, again, still having some viral load that could be potentially contagious in that 5 days after symptoms begin. So it is a large range. Again, unfortunately, it is a couple days prior to symptoms. 2 to 3 days after symptoms start is when you really have that viral peak, and then it starts to go down after that point. So.
All right. I don't know if you guys know this question, but Jerry just asked, can people who have COVID donate organs?
Great question.
In limited circumstances, they can. I'm aware of recently of someone with COVID who was able to donate 2 kidneys. It's basically on a case-by-case basis, and so lots of different considerations, but they can, on occasion, do that.
Okay. Last question. You guys got to roll, don't you? You guys busy? Okay, I'll get you out of here. Lesko wants to know, are treatment protocols used at the hospital the same for Delta versus Omicron, given they are presenting different types of symptoms? or is COVID COVID?
Yeah, I would say that COVID is COVID. You know, there may be some outliers and some people presenting with more atypical symptoms, but people are really presenting with the same symptoms. These variants are pretty much all the same. Now, there is some spectrum in there from variant to variant, but it's overall greatly the same virus. It overall greatly causes the same pathology. We are treating them as we would the original ancestral Wuhan strain. And the inpatient in the hospital, the treatment modalities continue to be remdesivir. But again, earlier is better. You know, usually if you're more than 7 days out, remdesivir is not really going to have an effect in the hospital. But it's remdesivir, that antiviral medicine. It is steroids if you meet criteria to get steroids, meaning you are now being placed on oxygen, or if you've been on oxygen in the past, normally, if your oxygen requirement goes up. And then, of course, the blood thinner, the anticoagulation, we use that as well. So that has really remained stable for the majority of the pandemic at this point. What we are hoping is that outpatient therapies, those people who are not coming to the hospital yet, but who are at risk of coming to the hospital, can get those prescriptions for Paxlovid or molnupiravir, or get those monoclonal antibodies, because so far the early data, certainly for the oral medicines, have shown that it does reduce your risk of going to the hospital. And we also know that the monoclonal antibodies, when we do have the supply, that also significantly reduces your ability to go to the hospital. So those are basically the outpatient and inpatient treatment modalities, which really have not changed as far as the inpatients go.
Okay, now that I promise this is the last question, but I want to touch on it because we've had several people ask about kids under 5 being able to get vaccinated, and especially since Kansas just recently reported another child death. But do we have any updates on when kids under the age of 5 will be able to get vaccinated? Are we any closer to knowing that?
I don't actually know if there's been an update in regards to the timeline.
I know they went back and have asked for more data, but I don't know the timeline of when that would.
I saw a story today. There might be something in the mainstream news outlets about that. I thought Dr. Fauci or some had made a comment. Hopefully it's going to be sooner than 6 months, and maybe earlier in the spring. Maybe earlier than we had initially thought. So, but
all right, that's some good news.
Yeah.
All right.
And there's still great opportunity for. Oh, sorry, Dana. But I was going to say there's great opportunity in that 5 to 18 range. We're still not where we could or should be in vaccination rates for those.
And
kids.
on the point of vaccination, exactly, Tim. I see there was a recent MMWR that was published. So that's again the CDC's publication, looking at those who are vaccinated 12 to 18, and helping reduce that chance of multi-system inflammatory syndrome in children, or MIS-C, and the vaccine actually helps prevent that. And the fact that after the vaccination rollout, they found that 95% of the children who did have that, who were between 12 and 18, were actually unvaccinated. So vaccination also does help prevent or reduce your chance, or your child's chance, of getting the multi-system inflammatory disorder as well.
And they're seeing that seeing that at Children's now, I think, with an increase in that with particularly unvaccinated children.
All right. We'll make it a three-peat next Friday. You guys got to come back.
Yeah.
Awesome.
Let's do it. Okay, so let's get to some final thoughts. Again, so glad you're both with us today. Dr. Williamson, I'll let you get us started.
Yeah, I think there's hope on the horizon. This surge, I think, has the potential to really peak in the next couple of weeks, but that depends on what we do and our behaviors. And so I know we sound like broken records, but it really will depend on if we are masking, if we're getting vaccinated, and we're staying out of, crowded areas, indoors, unmasked. So it's really up to all of us to have that peak actually occur.
Amanda?
Yeah, yesterday I was talking to someone and we were just sort of talking about there felt like there was hope last year at this time because we were so excited about the vaccine coming out. And then over the summer, it felt really good because our numbers were going down. And then we were sort of hit with this. And then in the last couple of weeks with our staffing shortages, the way they've been, which I think there has been a little bit of hope as it's come to that. We've seen the projections that our team has been doing. And it does look like we just have to hang in there for a little bit longer. The part that kind of concerns me is what you just said, avoid going to those indoor crowded venues right now or even homes. And we've got some exciting sports times coming up, and I just worry a little bit about people interacting with other people outside of their normal household, and what those masking practices might look like, and could that potentially lead to another, maybe a mini surge. So just something to keep in mind. If you can hold out, stay in your house, or just continue to have really, really good masking practices. And if you aren't vaccinated, there is plenty out there, so go ahead and get signed up for that.
Dr. Hawkinson.
Yeah, be safe out in the cold. I think it is going to be warming up this weekend just a little bit. But just also, we've heard about endemic, and we really do believe now the virus is endemic, and that's not a bad word. All that means is that the virus is here with us. It's among us. It probably will be for quite some time, and so the way to do that and the way to get through your life is to do things thoughtfully and understand the best practices that you can do to keep yourself safe, keep your bubble safe, and your community safe. And those continue to be those basic things that we've been talking about for so long. Masking, distancing, understanding what kind of situations you're going into, hand hygiene, and of course vaccination. And if we all do that, we will be able to come through this. Hopefully any further surges will not be like they are now, and we can keep people healthy and keep doing those things that we want to do, so we can keep our businesses open, people employed, we can keep our children in childcare, and do all those things. So I think the endemic is not a bad word. I think it just means that we have to be thoughtful in the way we go about our daily business.
Well said, Doc Hawk. Thanks so much. And thank you all for being with us today. Don't forget, you can catch our show anytime on Facebook and on YouTube. Coming up on Monday, the metro area has been hit in crisis mode for some time now with the blood supply. We have talked about this several times on the show. We're going to see where it stands now and how and where you can go to donate. Also, COVID is hitting a lot of families hard, from lack of jobs to limited money for family expenses. Harvesters Community Food Network says there are a lot of families struggling to keep food on the table, and even worse, food in the bellies of our children. The ways Harvesters is helping and what you can do to help this community. But before we go, we have got some brand spanking new Chiefs fans that we want to introduce you to. We know this year has gotten off to quite a rough start, and we just want to start our weekend with a smile and, of course, some good vibes sent out to our KC Chiefs. So thank you all for being with us today. We will see you back here on Monday.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.